Morning, morning everyone. I hope you're all well. Looks like we've got a few people in already. That's good. Yeah, sorry about the shorter intro this morning. Oh my god, 30 seconds to go. Right. So we've done the sacral plexus last week. Finished that off. We've got a couple of bits left to do on that. Just bring up that. Yeah, so we're going to have a look at the cutaneous nerves around that region as well. Finish off those, and then we'll go into the lumbar spine. Okay, so lumbar spine is always a good one. It's kind of one where we spend a lot of time with people, because that's the majority of what people come in with is problems with their lower back usually. And if you read or get reports at MRIs and things like that, then it's obviously useful to know what they're talking about when you receive that information. Let me just, why am I missing that? Good morning. There we go. Hi, Becky. Morning, Martin. Good to see the usual suspects in. Right. So let's get going with this one. Hopefully it's this one. Oh, that'll give you nightmares. Okay, so that's from last week. Here we go. So we're just finishing off this one then. We talked about this a little bit before. So there's three main types of nerves that we're interested in. So we've got motor nerves, obviously going to the muscles. There's nerves that go to the joint, so our articulatory nerves. And then we've got nerves that go to the skin. And they're obviously different branches of that. But the skin nerves are called cutaneous nerves, and they give us feedback from what's going on in and around the skin region. So just wanted to go over these for the sacral region. That it was a bit too much to cover last time, so but we have looked at these on the hip as well. Okay, so it's not as if this is completely brand new. Just get my arrow there. So we've got these nerves called cluneal nerves that they supply the skin over the gluteal region. Okay, so these nerves emerge from the posterior aspect of the sacrum, so you can see them popping through here. And as they emerge, they stay superficial and they stay in the skin. And so this middle cluneal nerve is from S1 to S3. It's purely sensory, that's all it does, and it detects sensation over the skin of the glute maximus. Now, this is a big part of what we call DNM, so dermoneuromodulation. And the thought process is that sometimes these nerves, for whatever reason, they get stretched, they get compressed, they come under some kind of ischemic stress, so they lose their blood supply for whatever reason, and then you get odd sensations in the skin. And of course, what we've always been taught is that if there's a problem around this area, then you think about the structures underneath. So you don't think about the skin. So you think about glute medius, you think about the sacroiliac joint, think about that's pretty much it really for that region. But those are the things. So it's the deeper structures that we're concerned about. So yeah, DNM is all about talking about just thinking about the superficial structures a little bit more. Let's start there. And then if we do some treatment and it doesn't really have any effect there, then it may be deeper structures that are involved, or it could be referred pain from somewhere else. Pain is not great at letting us know where the problem is, as we know. But if we have that kind of layered approach, then that helps us kind of systematically work through the structures in that particular region. So yeah, so that's your middle cluneal nerves. So skin over glute maximus for that one. And then we've got these inferior cluneal. So these ones, this is a branch of the posterior femoral cutaneous nerve, which is what we've had a look at previously. and this provides sensation to the skin over the inferior part of the buttocks, so kind of like where your sit bones are. As you can see, it's right around your ischial tuberosity just there. So again, strange sensations around that kind of area where you've got a kind of pain or ache or whatever, maybe shooting sensations in and around the kind of gluteal fold, then maybe it's something to do with these inferior clineal nerves. Very, very simple treatment, really, because we don't really know how it works, but the theory is that if something is compressed, then we try to give it space. If something has been stretched in a particular direction, so kind of like a skin stretch rather than anything else, then we can move the skin tissue back over into the opposite direction to see if that changes the symptoms. So you're basically just playing around with the skin, and then you move the skin in different directions, and then whichever direction it feels more comfortable in, then you keep it in that direction for a bit, hold it there, wait until the symptoms ease, and then let it go back to normal, and then retest the area and see how it feels. And if it is a clineal nerve problem or a superficial nerve problem, then it changes pretty much straight away. And sometimes it can be quite fascinating for us and for the patient. They're like, "How the hell did you do that?" Literally just moved the skin, and it took the pain away. So yeah, again, we know the outcome. We don't really know the mechanism. There are some theories behind it. So that, yeah, this is what these are the areas that they cover. So superior clineal nerve up here, middle around here, and then inferior all around here, and then that posterior femoral cutaneous, which we looked at previously, would supply that region. It's very similar to a myofascial release type technique, but it's not aiming at the muscles underneath, basically. So when I was taught myofascial stuff, it was all about moving the fascia, moving the muscles, and it's a lot lighter touch. Sometimes, but depends on who does it, I guess. But sometimes myofascial stuff is very light. This is literally just a skin drag. So I think it's a neurological explanation for how myofascial release works. Okay, so yeah, like I said previously, when I was taught MFR, we were taught to push. So say someone was kyphotic, to get them into a more upright position, we would push the fascia on their back towards their glutes, and hold it there for like 5 minutes. And what we were taught was happening was we were deforming fascia, and we were trying to push it back the other way. So we would kind of aim upwards on the front of the chest and then downwards on the back to try and reposition that person's thorax. But I mean, we know that that's not true now, and but we know that people got relief from the technique, and so this, I think, is a more plausible reasoning as to why that technique helps. Okay, so yeah, it's exactly the same. I mean, all manual therapy is dermoneuromodulation, because you have to contact the skin to do any soft tissue work on anybody. So the skin has to be involved somehow. Cool, right. I think that's it. Yeah, that's it. So that it was just a quick one, just to finish off those superficial nerves. And then we'll move on to lumbar spine. So we've got going back to the bones and the joints, and it's always nice to do that for me, because then I don't have any revision to do. There's a lot of revision to do for the sacral plexus. So lumbar spine joint anatomy, bone anatomy. And I'm going to go through each section of the lumbar vertebra, and so that you know exactly what bit's what. Okay, so that's the plan. Sorry about all the text. Let me just get me out of the way up here somewhere. Okay, so this is your vertebral column. So we've got from this region here, so this blue zone is the cervical region, so that's your neck. Then the orange zone is thoracics. The green zone is the lumbar zone, so that's the area that we're focusing on now, and this is what we've just looked at. So we've looked at this purple zone here and the yellow zone with the coccyx. So we've done that bit, so we're going to work our way up. Okay, so lumbars next around this region here. Here it's got 5 lumbars, but we already know that that may not be the case. There may be 4 or there may be 6. So we'll have a look at some of those anomalies as well. Each of the vertebrae, you can see here on this side view, has got a disc in between it, and we'll have a look at discs in particular when we look at the passive structures, so in subsequent videos. And it's also got a sticky out bit on the back here, so this is a posterior view, and these little knobbly bits at the back, these are the bits that you can feel when you feel down the back of your spine. So if you feel on the back of your spine now, you'll be able to feel these bony protrusions in the middle of your back, and that is these bits here. These are the spinous processes of the lumbar spine in particular, if you're feeling in the lower back. We've got this curve, natural curve within the spine. This is a more common curve, but there are different curves out there as well, all entirely normal. Some are what we call antalgic. So if someone has symptoms somewhere, then they may adapt a different position to move away from those symptoms. But that is usually only temporary until the symptoms abate, and then they come back to their normal position again. Okay, so one of the issues we've got is we see people when they're in pain, usually. So when we're assessing people, we're looking at people when they've got a painful stimulus. So we might not be seeing a reflection of what their true position is. So we're trying to, and if we've never seen them before, then we don't know what that is. So we then always try and compare it to normal, in inverted commas, or the usual, which is this one. But that may not be the usual for that person, but we don't know because we've never seen them before. So yeah, just some things to think about if you're assessing spines. So prior to adulthood, we've got 32 to 34 vertebra, and then the typical adult vertebral column has got 26 vertebra. Although each individual vertebra is unique, morphologically, all vertebra contain features that allow them to be grouped into one of 5 regions. Okay, so let's go down to the region we're interested in, which is this one. So the lumbar region, the vertebrae are numbered L1 to L5, beginning with the most cephalic or cephalic, however you pronounce it, lumbar vertebra, which is around here. Okay, so that level there. And just above T12, so thoracic vertebra number 12, that one has got a rib. So one of the characteristics of the thoracics is that it has additional joints where the ribs attach. The lumbar spine doesn't have that. So the first vertebra that doesn't have it underneath the thoracics is usually L1. Okay, so that's a good starting point. So that's a kind of overview of the whole spine and then the lumbars. This is how we develop. So we've got, if I just move me out of the way again. So we've got the baby here. So it's kind of like a C-shaped curve. And then as we then start to grow, so newborn, you start to develop a little bit of a lordosis in the lumbar spine. And then as we're stood, we then start to get that lordosis kyphosis. And then in adulthood, we should have this usual lordotic curve in the neck, and that's this bit here. So that means that the curve goes inwards, okay, so anteriorly. Then we have this outward curve of the thoracic spine, usually, and that is going posteriorly. So we've got like a backwards curve. Then we have another inwards curve of the lumbars just here, and then an outwards curve of the sacrum, and we've had a look at that with the angle of the sacrum on the last one. Okay, so that's what's usual, that's what should occur. So kyphosis is an anterior concavity of the vertebral column. So it's the concave side is the side that's caving in. Okay, so remember that. So the concavity is at the front anteriorly, so it sticks out posteriorly. Okay, so you have a convexity posteriorly. Yeah, so kyphotic curve is one that develops during the fetal period, so it's considered a primary curve. The thoracic and sacral regions consist of kyphotic curves. So that's this region here, okay, and the sacral region down here, which is what we were looking at over the last couple of weeks. A lordosis is a posterior concavity of the vertebral column. So here, the lower back is caving in that area. So that's a concavity, and or it's yeah, you just say it's like an inward curve in that area. Okay, so kind of outward curve here, inward curve here, and that again is usual. Okay, that's what should happen. Lordotic curves develop after birth due to extension of the vertebral column and the preparation for the need to bear weight. Okay, so as we start to develop and we're moving around and standing on 2 feet, then the shape of our spine changes to absorb load, basically. So it's considered a secondary curve, and the cervical and lumbar regions consist of lordotic curves. So in the neck, it curves in, and in the lower back, it curves in. Okay, so we should have a couple of curving in bits and a couple of curving out bits. That's usual. The cervical lordosis develops due to raising and holding the head erect, and the lumbar lordosis begins to develop during crawling and then continues to develop to upright posture, standing and walking. Okay, so we've got this developmental process where our body adapts as we start doing new things. Okay. Cool. So that's a kind of introduction to those. Let me just pop me up here. So this is a lumbar vertebra. This is the shape of vertebra are quite similar, but they have some distinct differences. As I was saying, the thoracic ones have got additional joints on. So if you had a bag of vertebra and you had to pick one out and guess which one it was, you should be able to pick up certain things on the vertebra and go, oh yeah, that looks like a lumbar because of this, this, this. That looks like a thoracic one because of this, this, this. Okay, so there are certain characteristics. So in a lumbar vertebra, it's got a really big body. Okay, it's the lowest part of the spine, so it's absorbing a lot of load. So it makes sense that the body is bigger there than anywhere else. Okay, so that's the vertebral body just there. These bits here, there and there, these are called pedicles. Okay, so it's like little feet coming off of the body. Yeah, so we've got these little feet coming off here, and then on the back of those little feet, we've got this curve of bone around here, all the way around, and that's called a lamina. Okay, so we've got the main body just here, these little feet projections coming off of it, and then this curve of bone which has got loads of other bits sticking out of it as well, and that's called the lamina just there. So when you look at MRI scans, or you get an MRI report about a lumbar spine assessment, they will often mention some of these bony landmarks on there, and as well as some of the other tissue that we'll add on as we go through. So it's useful to know where they are so that you can then understand what's going on. Okay, the kind of things that they've found. So the pedicle here joins onto the lamina, goes all the way around, joins onto the other pedicle. And if we have a look on this one, so there's the body, so side view, there's the pedicle just there. And then obviously we can't see the curve of the lamina, but we know that it attaches onto the opposite side, onto that left side. Now the pedicle here isn't just a straight bit of bone. It's got these notches in here and here. Okay, so we've got a superior vertebral notch, which is this one because it's the most superior, and then an inferior vertebral notch just here because it's inferior. Okay, so these are really key because they, so if you imagine you've got one vertebra and then the other one on top. So you've got the superior notch of one vertebra and then the inferior notch of another. And so they create like a portal, like a window here. Yeah, so if you imagine another vertebra underneath here, you're going to have that shape notch just around about here. Yeah, so the superior notch of the one below is going to be about there. So that's going to create this oval kind of shaped window, and then through that window, through those both of those notches, that's where your nerve roots are going to come through. Okay, so through, yeah, inferior vertebral notch, superior vertebral notch, they're going to be useful later on. Okay, so that's that bit there. Then we've got these sticky out bits here. Okay, and these are very different to the thoracic vertebra, again because of the attachments of the ribs. So the sticky out bits to the side, they're processes. Okay, see, this is a process as well, but because it's coming out to the side, it's called a transverse process. Okay, so a side sticky out bit is a transverse process. Yeah. And then the one at the back, these are the ones that you could feel. So the ones we were just looking at earlier, that's a spinous process. So we've got transverse processes to the sides and then spinous process at the back. We do have these little projections on each of the what we call facet joints. So they're the joins. So like here, that one there, yeah, and then if you imagine another vertebra on top of it, it will join up with the bottom of the one that's above. Yeah, so the inferior articular facet here will join in with the superior articular facet there, and then they'll connect together. And I'll show you a video in a sec so you can have a look. But there's a little mammillary process just on the ends of those. You wouldn't be able to detect those through palpation or anything. The only bits you can feel are these bits here, the spinous process. Yeah, everything else, there's too much tissue in the way. Okay, even transverse processes you might do on someone that's got very, very little kind of body tissue, so but either fat mass or muscle mass. But if you've got any kind of muscle mass around here, you're going to struggle to feel a transverse process. Okay, and definitely not get down to an articular process. So these joins here, can you see the direction in which they are orientated? So we've got a top-down view on this left-hand side here, and the joins are kind of like that. Yeah, so the next vertebra above is going to slot in exactly the same way. And what that means is when they're slotted in all together, they can bend forward and bend backwards, or bend back to the normal position quite easily, because they'll just glide past each other. Yeah, but when you're stood upright, if you've got one there and then another one there and you try to rotate, there's very, very little room for rotation because of the shape of these joints. Okay, so if you try to rotate the lumbar spine, they only rotate about 2 or 3 degrees. Okay, so tiny amount. So with 5 vertebra on average in the lumbar spine, you're going to get about 15 degrees rotation out of the lumbar spine. Okay, so very, very little movement, 2 to 3 degrees. So yeah, the shape of the joint will dictate how that particular area moves. Okay, and then we've got this gap in the middle. This is the vertebral foramen. So anything with a foramen, we've seen that before in the pelvis. We had the obturator foramen, and it was a hole that things pass through. Well, this hole that things pass through is the spinal cord. So, well, in this case, spinal nerves, because of the lumbar spine. But it's a pathway for the nerves to come through, and then when they reach their designated level that they need to exit, they then exit via these notches. Okay, so you'll have nerves coming down, and then they'll come out in between the notches, and then some more will go down to the next level, and then they'll come out, and so on and so on. So as we layer on the tissue for this particular section, we'll go into where the nerves go as well. So we've obviously had a look at the end result of it with the feet and the knees and the hips. And then we've started to hone into the sacral region. So we're starting to get into the kind of origin of those nerves. But now we're going to have a look where they attach onto the spine. Okay, so that'll be in a few weeks' time. Cool. So that's a kind of general overview. Let's just show you a little video. Is that the right one? I think that might be the right one. a sec. Let me just change my that's weird, it's got rid of my camera. You're going to see my green screen now. There you go. Bear with me a sec, let me just get rid of that. Change that. There we go, that's better. Okay, cool. So let's have a look at this. So this is basically just a video of exactly what we've just seen, but this is on a real cadaver. So if I just pop that there. So there's the vertebral body. These are the pedicles here and here. This is the facet joint. So this will be the superior facet. And then that's the transverse process, so side stick out bit, and then spinous process just there. And can you see how kind of bobbly everything is? Yeah, muscles attach onto these, so they pull in all different directions, and it looks as if that one is a bit longer than that, a bit shorter than that one. Okay, maybe just the angle, but sometimes you get different sizes of things on different sides as well, and that's again entirely normal. Okay, so that's all the stuff that we've just seen on the PowerPoints. So there's your, yeah, definitely is longer. Look, so that transverse process compared to that one there. There's the notches. So there's your spinous process. And then this is how they join together. So if I just pause that there. So yeah, we've got the superior facets here. So remember how they were orientated on that picture. So we've got this kind of direction here, and then the inferior facets here. So now hopefully you can see what I mean. So if you need to flex forward, so bending forward, those vertebrae will nice and easily go forward, because there's nothing to stop them. But if you're in an upright position and then you try to rotate, you're going to be limited with rotation. I mean, these are dry bones, so there's no connective tissue on them. You'll see some with connective tissue on in a second. And in between here, we've got the articular cartilage as well. So there's very, very little space for them to rotate. And so that's why we don't get very much rotation here. We get the majority of it from the thoracic spine, because they're shaped differently. Okay, let's have a look. So they've just made up a disc in the middle there. That's we'll have a look at discs in more detail as well. Yeah, there you go. So that's the limit of rotation there. Okay, you have to, if you blink, you miss it. Let me just do that again. Here we go. There it is. Okay, so they're just moving that from side to side. You can see how little rotation that you've got there. Cool. So that's basically what we've just seen. So let's have a look at that in a bit more detail. Just move me down here. So I've got a slide for each section. Obviously, I've gone through it already, so we'll just kind of do this as a bit of an overview. So the vertebral body is the large, somewhat oval-shaped anterior portion of the vertebra. Its posterior side forms the anterior boundary of the vertebral foramen. So the back of the vertebral body here forms the front of the whole. Okay, so the front of the foramen. And that's useful for later, for when we start looking at the position of ligaments. Okay, because there are some ligaments that fix to the back of the body, some ligaments that fix to this bit of the lamina. Okay, and it can be a bit confusing if you're not sure, if you can't get like a 3D model in your head. But yeah, hopefully it will make sense as we start to go through. So the vertebral bodies of adjacent vertebra in an articulated vertebral column are joined by intervertebral discs, and these sit on top of the bodies. The discs get their nutrition from the bodies. Okay, so as you move and squash the disc, as it moves back up again and the disc kind of plumps up, it will rehydrate from drawing nutrients and fluid from the vertebral body. Okay, so that's how it gets its nutrition. So that's the body. And then we've got the pedicles. So the pedicles are two short, thick bony processes that project posteriorly, so this way, here and here, from the left and right sides of the body. Okay, so we talked about those already. So those are the little feet. pedicles means. Okay. Then we've got the lamina, two flat plates of bone that project in a posterior and medial direction. So from the pedicles, it comes back and medially, and then they join together in the middle and then form the spinous process at the back. Okay, so that's where we get this arch from. Okay, this ring around where the nerves will eventually be. So the right and left lamina join in the middle at the base of the spinous process. So around here. Okay, so that's the so from there, around there to there, that's the lamina. All right, that's what that section is. Then we've got the spinous process at the back. So this is the bit that projects posteriorly at the midline junction of the lamina. So remember the lamina was this bit. There's your spinous process. Spinous process varies in length, diameter, orientation depending upon the vertebral region. Yeah, so in the lumbars, they pretty much stick straight backwards. So you can see that on there, quite thick, poking straight out the back. In the thoracics, they're quite thin, and they're a bit like a witch's nose. So they kind of droop downwards and thin and go over the vertebra below. Okay, so they're slightly different there. And then in the cervicals, they're different again. So the bony knobs that can be felt whilst palpating the midline of someone's back are the tips of the spinous process. So it's that bit that you can feel. Okay. Interestingly, we're not very good at feeling those bits reliably. Yeah. So the reliability of spinous process palpation, lumbar spine's not too bad, cervical's not too bad, but the thoracics is all over the place. Okay, so and it doesn't matter whether you're an experienced palpator or brand new, we're all pretty rubbish at it. So if you think you're on T2, T3, the further you go down, the worse it is. You're probably not. Okay, so you'll be around that region, but it's not very accurate. Okay, palpation is not very accurate. What they've found though is that even though it's inaccurate, you can palpate the same spot again and again. So if you so intra-rater reliability is quite good, but it's the reliability is good, but the accuracy is poor. So even though you're reliably getting the same spot every time, what you think might be T4 and you're like bang on what you think is T4 all the time, it might not be T4 that you're feeling, but you're hitting the same spot every time. So in terms of reassessing, that's quite useful to be reliable, but it's not very useful because you're not in the right place. Okay, so yeah, but we're generally not very good at it. The transverse processes, these side sticky out bits, they project laterally in the horizontal plane, so out to the sides, and they're the junction between the lamina and the pedicle. Okay, so lamina here, pedicle here, and the transverse process will stick out in between those 2 points. Okay. Superior articular process, bony protrusion projecting superiorly from the site where the pedicles and the lamina meet. So that's this bit just here, and this is the join. These are often called facet joints. Okay, they're sometimes called zygapophyseal joints as well. I think I've mentioned this before. My anatomy teacher used to tell us off for calling them facet joints. She got quite annoyed that we didn't call them their original name. So these are zygapophyseal joints. The join here will join with the inferior one of the one above, and that's where your guide of movement will occur. So as we were showing on the video, okay, zygapophyseal joints. So with the pars, okay, so this is a good bit. So the pars interarticularis, the part in between the joint, is a small segment of bone joining the superior and inferior articular processes to each other. So in between this bit, so just inside of your transverse process. So it's whether I can get it on here, it'll be around there, that kind of area there. So imagine that transverse process wasn't there. That's the superior articular process. There's the inferior one, and then the pars is that bit in between. Okay, and that's quite useful, and we'll have a look at the pathology of this region as well. We'll start to add that in, because that is where you can get what we call a Scotty dog fracture. Okay, so when you get an x-ray of this area, if someone has fractured that point in between there, it looks like a Scotty dog with a collar on, and the collar is the fracture. So that would be the dog's ear. That's where the collar will be, and then that will be his front legs, and then that will be his hind legs. Okay, I'll see if I can get in it. Well, we'll show you the image when we look at the pathology section. But that's the it's very common in gymnasts, cricketers, because of a lot of extension and rotation in the sport, so they're more susceptible to pars defects. So you may have heard of that with in the various sports that you've been involved in. Inferior articular process. So this is a bony protrusion projecting inferiorly. So that's this one, and then that will obviously meet up with the superior facet of the one below. Okay. Cool. Done that one. Yeah. So in an articulated vertebral column, the superior articular process joins an inferior articular process from a superior vertebra to form a synovial joint. So these joints, that one there, which joins with the superior from below, has got a capsule around it. Okay, and it's called a zygapophyseal joint, which is what we were saying before, or more commonly called a facet joint. So let's have a look at that. Now this is one with a lot of the connective tissue still left on. So you can see the amount of tissue. Obviously it's taken all of the muscles away and the skin away, but it's left a lot of ligaments on, and you'll see in a sec. So here's your inferior joint and superior joint here, transverse process, spinous processes there. So this is the bit where we're looking at, the facet joints. There's the superior, there's the inferior joining together. Okay, and then that's what they look like with all the stuff left on. Okay, so if I just pause that there. So that's the joint line around there. You can just about make it out. So there's your transverse process. So that all of this connective tissue stuff, this is all ligamentous and fascial tissue. That there is a ligament called the supraspinous ligament that goes over the spinous processes. So that there's a lot of stuff around here, and there's the joint capsule. So that's the bit that will produce synovial fluid to help aid with the movement of that joint. And there you go. You can see the tiny amount of movement that you get. Look at that. Okay. So there's not a lot at all. So if you think about what we've just seen there, if I just go back there. So as they're moving them forward and back like that, you know when you get those little clicks and pops in your back? Hopefully now you can visualize what's happening. So that capsule is full of fluid, and then as you move the capsule and stretch the capsule, you'll get a little click. Okay, so it's nothing to do with bone rubbing on bone or bones being repositioned or anything like that. It's a release of gas from within that synovial capsule that creates the pop, and hopefully that movement there just shows. So if we concentrate on this area here, there you go, you can see it there. So you can see that tiny little movement, and it just goes pop as you move it to the end of the range. And we'll explore the rest of these as we go through, but there's where the nerves will come through. So those are those foramen at the side that we were talking about before, so where the superior and inferior notches are. Cool. So that's your facet joints or zygapophyseal joints. There we go. So yeah, this is your vertebral arch. So several individual vertebral features collectively from other named features. The pedicles and the lamina on the posterior side of the vertebra form a U-shaped structure called the vertebral arch. So all the way around there is the vertebral arch, and that's basically the lamina section all around there. The attachment of the vertebral arch to the posterior margin of the vertebra form a large hole called the vertebral foramen. So that's this bit just here, and that's where the nerves will go through. When vertebrae are articulating with each other, adjacent vertebral foramina form the vertebral spinal canal. So if you imagine that, another one on top, another one on top, that forms this pathway for the spinal cord to go down. Okay, and this you may not know if you've not really looked at this before, but the spinal cord only goes to about the level of L1, L2. Okay, so anything below that, there's no cord. It's like the ends of nerves. Okay, and we call it the cauda equina. We'll have a look at that when we get to the nerves. So these are the different shapes of the joints that we were just talking about. So we're focusing on this one, lumbar spine, and this is the shape of the facet joints. So we've got a short horizontal spinous process, large vertebral body, large thick facet joints, and the vertebral facets are at a 90-degree sagittal plane. So that's why we don't get much rotation. Okay. As we go through the vertebra, I'll explore the other two in a bit more detail, but we'll leave it just to the lumbars for now. Okay, cool. So when two vertebrae articulate, three joints are formed, one anteriorly and two posteriorly. So posteriorly, we've got these facet joints, the zygapophyseal joints, and then anteriorly, we've got the intervertebral joint at the front there. Okay. Anteriorly between the vertebral bodies is the disc. So we've got the intervertebral disc just there, which is classified as a cartilaginous joint. There's no capsule around it. It's just the cartilage cushioning. And then intervertebral discs are named according to discs adjacent, the discs adjacent vertebra. So for example, a disc between L2 and L3 vertebra is the L2, L3 disc. Easy as that. Okay. The type of movement occurring at the facet joints is determined by the orientation of the articular facets, and we talked about that. So lumbar spine, really good at going forward and backwards, but not very good at rotation. Side bend, not very good at that either, just because of the space, and the structure of them doesn't lend to a good side bend. Okay. So these are the different movements that you can have in the vertebral column. Just move me out of the way here. So if we focus again on the lumbar spine, highly mobile region of the vertebral column, movements include flexion, extension, and they're greatest in this region, so more than anywhere else, and then side bending, but very limited in terms of rotation, as we said. Okay, so that's what you're going to get out of that area. And then lastly, just to finish off for today, these are some of the anomalies, and we've looked at these before. So this is from this book, Bergman's Comprehensive Encyclopedia of Human Anatomic Variation. So they looked at 631 bodies. 77% had 5 vertebrae, 20% pretty much had 6, only 1% had 4, and 0.2 had 7. Okay, yeah, usually it's 5, but that's quite high. That 20% with 6 lumbar vertebra. Okay, so there are variations out there. So as you're palpating down someone's lumbar spine, if you feel a 6th and you're like, is that me or is that them? Okay, it might be them, and it might be normal. So here we've got a lumbar spine section that has kind of connected itself to the sacrum, so it's not free. Yeah, so it's call it either sacralized or lumbarized vertebra. So, and then this one here as well. Okay, so again, it's kind of like the formation of a lumbar vertebra, but it's not quite got there, and it started to form, but is still firmly attached to the sacrum. So they're going to have really limited, well, no movement out of that vertebra there, or this one here, because of the attachment to the sacrum, not like the ones above. Okay, so again, if you're seeing weird movements, it might be because of their anatomy. Okay. This is the classification, the Castelvi classification for different types of lumbarized sacrum or sacralized lumbar, however you want to say it. Okay, so we've got type 1 through to type 4, is that right? Yeah, you've got a few different variations of them as well. And yeah, you can have a look at that at your leisure. But I just wanted to show you that it's not always like it is in the textbook, as we know. And if you want to know for sure that it's not always like it is in the textbook, then I am in London this Wednesday. We've had a couple of people transfer from this course onto our next one. So we've got some spaces come up for Wednesday. So if you can rejig things or you're not doing anything on Wednesday, then there are some spaces on the anatomy labs for this week. And I don't do them very often anymore. I'm only doing once a year at the moment. So if you don't do this one, then it is next July when the next one's taking place. So yeah, if you can make it, that'd be great. Or if you know someone who might be interested, then you can let them know as well. Okay, cool. I will see you next Monday, and we will look at the ligaments of the lumbar vertebra. Okay, we'll start to add on the layers as we go. I'll see you then.